Hey folks, welcome to the EMSNation podcast. I'm your host, Faizan Arshad. Today we have a very special episode which we recorded in Miami, Florida at the annual Yale Caribbean Point of Care Ultrasound Conference. And as you guys know, we are advocates of point of care ultrasonography and certainly look forward to a bright future with additional research and point-of-care applications with ultrasound in the pre-hospital space. Certainly, we're already making arguments for the use of critical care ultrasound in the pre-hospital space for helicopter EMS or HEMS operations, medevac, critical care transport. But even looking forward to generalized ALS care and paramedic support, additional guidance on pathophysiology, as well as procedural guidance, and certainly on trauma patients using the extended FAST exam, the focused assessment of sonography in trauma, while the patient is already in the back of the ambulance being transported, to further guide your management not only on potential injuries, including pneumothorax, pericardial tamponade, free fluid in the abdomen, bladder rupture, any number of diagnoses you can use in the extended FAST exam to help guide your management of the trauma patient, and also to select the appropriate receiving center, because a positive FAST exam while you have the patient loaded in the ambulance may certainly guide or contribute to your decisions on where the patient should be transported. So we have several episodes in the queue related to EMS POCUS, or we also call it pre-hospital ultrasound. So certainly hope you guys enjoy. This one is by Dr. Drake Coffey, who did his ultrasound fellowship at Yale as well, and is on the EFAST exam. So please stand by, and I certainly hope you guys enjoy.
So you're at a couple of windows to look for other pathology in the chest. It is probably, this is all historical, so we're going to blow through it. It's probably the first really well-established point-of-care ultrasound modality. None of that really matters. We're going to really focus on getting you in the habit of thinking about and doing an EFAST when you do EFAST. It only takes a second to add the other looks, and it can really change your patient's trajectories. So the pros of the exam, one of the most important things to note here is what I bolded. It's repeatable, and I'm going to touch on that again later. Do a FAST as soon as you think about it. Go back and do another FAST a half hour later, and just make sure that nothing has changed. And I'll show you some examples of how that changed lives. It's not necessarily the definitive imaging test. It historically was just a way to replace the diagnostic peritoneal lavage. It's that and a lot more, but it's not a CT scan. So you're not going to see everything on your FAST. You're just going to see what you need to know in the most important time period. It gets better as you get better. So as you do more of these and you pick up the probe, you'll learn how to do them better, and it gets better as you get better. So the four traditional views for the FAST are both of the upper quadrants, the pelvis, and a subxiphoid view of the heart with an asterisk there. We'll talk about that asterisk in a minute. In the right upper quadrant, you guys know about Morrison's pouch. So you have the kidney here, the liver here, and the interface between those two, the hepatorenal junction, is called Morrison's pouch. And we talk about a lot of this stuff in my Finding Fluid lecture. Make sure that you look not just in that space, but look around the liver above the diaphragm here, around the tip of the liver there, because those are other places that you'll find fluid, and often earlier than you'll find them actually in Morrison's pouch. How much fluid can you find? Probably, if you're pretty good, around 250 cc's. The average person can probably easily pick up around 350, 400 cc's. And again, sensitivity increases with higher volumes and with higher skill level. So I talked a little bit in the Finding Fluid lecture, characteristics of fluid are that it kind of tracks into crevices and so forth. You're going to be looking for fluid that's kind of leaking and finding its way into every little. This is an example of a normal left upper quadrant. You guys all saw this in the hands-on session. Again, diaphragm is here. Usually the indicator is on here, so that's cephalad and that's caudad. And you'll just get used to seeing that, and you'll know when it's not right. You'll know that your probe is upside down because it just doesn't look right. So again, lots and lots of slides reiterating a lot of the same things. Before you leave the upper quadrant, so same technique on the left upper, similar technique on the left upper quadrant, looking in the splenorenal junction in the same way, fanning all the way through free fluid. Before you leave those quadrants, though, want you to kind of scan up into the chest to look for hemothorax. So in those same planes, in those same locations, rotate your probe. So tilt it up so you're getting more of a shot toward the chest where you can see that nice white diaphragm, and you're looking for that black triangle that's above the diaphragm that's not supposed to be there. If you don't see much and it's kind of grayed out, every time a person breathes you see this gray cloud kind of coming in and out of your screen, then that's an aerated lung and you're fine. If you don't see that and you see the spine marching on behind that, you know that that's not fine. So here's an example of what I'm talking about. So kidney, liver, that nice diaphragm. And here you have a decent mirror image, and it's kind of grayish and mirrored, and you don't see a spine that's going on beyond the diaphragm, so that's probably normal. Here, you see that liver, that nice diaphragm. You see a black triangle above the diaphragm that's not supposed to be there. And again, in an aerated lung, like up here, it's kind of gray and schmutzed out. And aerated lungs should be washing out everything above the diaphragm. Because as I said earlier, air scatters your sound waves and you don't get much back. So that's why you see a spine sign here when you have the pleural effusion. This fluid is allowing you to see through it. And it's giving you a nice, clear picture of the spine. So that's what we call the spine sign. Another example here, liver, fluid. This is a normal scan of the pelvic view in transverse orientation. It's kind of rhomboid. This is a fast-moving slide, but it demonstrates that you can't just put your probe in the middle of the bladder and call it a day. You can put your probe in the middle of the bladder and optimize your picture so you know that you're confident about what you're seeing. But then you must scan all the way through. So fan all the way to the end of that organ and then all the way the other way so that you're seeing the whole backside of it and not just one little segment. This is just for orientation purposes on a female pelvis. Patient's feet is on this side, patient's head is on this side. There's a vaginal stripe here, an endometrial stripe here. So this is a slightly anteverted uterus. It's flexed and inverted anteriorly. Normal free fluid in the pouch of Douglas would be back here. Starts to become abnormal as it rises along the superior surface of the uterus. Definitely pathologic if it's going anterior to the uterus. This is another example of a normal scan. This is transabdominal, normal pelvic scan, uterus, and so on. This is a normal example of the subxiphoid view. So now we've moved from the pelvis, we did left, we did right, we did pelvis, and now we're up in the subxiphoid view. This is a normal subxiphoid view of the heart. You can tell it's subxiphoid because we're looking at it through the liver. It looks, in a lot of cases, a lot like a peristernal long axis view, except up here you have liver, and that's how you know. There are other things, but we won't talk about that right now. We talked, in the groups that rotated with me, we talked about an easy way to go from the subxiphoid view, rotating into the sagittal plane, kind of going left and right a bit to see your IVC. This is the sagittal view of the IVC. You can see the hepatic vein dumping right into the IVC, right below the diaphragm. And so you would use that, not necessarily so much as part of a fast exam, but if you're resuscitating a patient, if you want to see if they're dry or wet fluid, if you think they're going to end up being fluid responsive or not. This is another example of a normal subxiphoid view. It kind of looks like a long axis view of the heart, except you're not really seeing the aortic outflow tract here, and there's liver in between your probe and the heart, so that's a subxiphoid view. This is the most sensitive view for a pericardial effusion, fluid around the heart. But it also gives you a good view of the sort of global function of the heart. I wouldn't make measurements from there, but you can tell. One quick thing about cardiac imaging in the FAST, and I'm going to blaze through this, it's not all that important. Statistically, or traditionally, the cardiac exam, the subxiphoid view is part of the FAST exam, but in blunt trauma, it's really, they're going to either be, if that happens, they're going to be dead. If they come in with a blunt trauma and a big pericardial effusion, they're going to be dead before they get to you. So you can take a look, but you're probably not going to see what you're looking for from blunt trauma. You're going to see that sort of injury with penetrating trauma more so. So don't kill yourself on this particular view and getting it just right. You'll have a lot of other clues that something else is wrong with the heart. So extended imaging, if you're trying to do your subxiphoid view and you can't get it, big bellies, they're supine, you're having a hard time getting your views, don't stay there for 5 minutes, just move up and do a quick peristernal long. You can use the same probe, you can use the curvilinear probe and just get a quick peristernal long axis view because you really just want to see is the heart squeezing or surrounded by fluid. And then when you do get your view, the most sensitive area for clinically significant diffusion, not a non-physiologic free fluid, would be in the posterior surface of the heart. So look here. You might always see a little bit here, but look posteriorly. This is an example in a patient with penetrating trauma. A little bit hard to see. You can kind of be fooled. You can kind of think, well, this is the right ventricle here, and all of this is sort of the left ventricle, and it looks okay. But this is the right ventricle border here. It's being squished. This is not only fresh blood, but clot. So there's a big massive clot there, and we've seen people who have that missed call, and missed large effusions like this, and you'll now recognize it again. So adding the extended part, you're basically going to add, we talked about the two things you're going to add are that quick flash up into the hemithorax down at the flanks, and now you're also going to add the pleural line so that you can check for pneumothoraces. So you're usually going to switch to the linear probe. You don't have to. I usually do the curvilinear probe for my fast exam, but you can switch to the linear probe because you can see the pleural interface in a lot more detail and use M mode with the linear probe. You're going to put your indicator for the patient's head and basically looking in the mid-axillary line, and I want you to start up here right under the clavicles, sort of at the apices of the lungs, but I don't want you to stop there. Take another second once you've looked at that and slide down a couple of interspaces. When people are supine on the bed and they're round, the most anterior part of the chest where a small 10% pneumothorax is going to go is not always at the apices. In fact, it's not usually at the apices. So if they're laying flat and their apices are actually lower than their anterior chest, you'll miss it. And I've had residents that miss pneumothoraces. So put your probes there and then just slide down a couple of interspaces until you're sure that the whole lung is exposed. And we're talking about trauma patients who are laying flat on a gurney, so you can't rely on your chest X-ray. This is your go-to device. When you get your probe there, this is what you're looking for. So you're going to have the near probe, subcutaneous fat. You're going to be looking for a rib. You're going to slide up and down a little bit until you can see another rib in your screen, right? Another thing that looks just like this. And then you're going to look at the line in between the two. And that's your pleural line. And you should see it kind of shimmer and slide like this one, kind of going back and forth. This is a real chest X-ray from a real trauma patient that was lying supine on a table. And who's going to call a pneumothorax here? Like, who's going to go and put a chest tube in right now? On this. No one. Even though it's obviously a trick question. That's the same guy. Big pneumothorax. Just happens to look like lung markings are going all the way to the edge because looking from anterior to posteriorly, they are. So you would see that with ultrasound, you wouldn't see that with chest X-ray. So a supine chest X-ray is only 34 to 60% sensitive for pneumothorax. You get better than 90% with ultrasound. Another example of what I'm talking about, the shimmering pleural line here. With every little breath, you see these tiny little Z lines, these artifacts that are kind of shimmering. That can't happen if you have a collapsed lung. Over here, it can kind of get tricky. You do see this shimmering line here. You do see this white line, but you don't see any coordinated movement below the line, independent of the top. Up here, all the tissues at the top are completely still, and the tissues at the bottom are moving. Over here, all the tissues at the top are completely still. Whatever this is below is completely still. That's important to understand when I talk about confirming this with M mode, because it was confusing for me when I first started using this. But when you're doing M mode, you've got that same picture up, rib, pleural interface. You hit the M mode button, and M mode drops a line in the middle of your screen. And what happens is your computer is now only going to pay attention to the data that it's getting on that line. And so it stretches what's happening on that line out over time, which is linearly on your screen. So if you have tissue above on the top part of the line that's completely still, and tissue below the line that's moving, the line below is going to get smudged, and it's going to look different than it does on top. And that's why you get what we call this sand on the beach thing, right? That's what you see here. That's good. If the tissues above the line are perfectly still, and the tissues below the line are also perfectly still, then you get a barcode that we call Stratosphere barcode sign, and that's not okay. Moving on to some positive findings. Again, a little bit subtle here. Anybody see anything wrong? When I was in fellowship, we did something called pass the pointer, where I didn't just kind of open it out there and let you docs. Like, we'd give you a pointer and you had to read the slide. You're getting off a little TV. But just yes or no, is this a normal or an abnormal study? Considering the previous slide said let's see some positives. It's subtle, right? Remember I talked about looking at the tip of the organs, at the tip of the spleen or liver? See that? That's subtle, but it's real. Here, again, you see something that looks either livery or spleeny. You see something that looks kidney-y, and you see fluid tracking between the crevices that's not supposed to be there. Right? I'm going to keep moving pretty rapid fire. Again, I just want you to see pictures. Look at them and see if you can find the Where's Waldo. This is an example of free fluid anterior to the uterus in a pelvic study, like I talked about before. So the pouch of Douglas is back here, and there's some fluid there, but it's also creeped all the way around anterior to the uterus there. Of the two views for the pelvis, I'd say the sagittal view is the easiest to not misinterpret. So if you have to just do one, do that one. I do both, but if you just need a quick look, use the sagittal view, because it's easier for your brain to understand the 3D anatomy there than in the transverse view where things are kind of layered sort of on top of each other. This is a positive, lots of fluid all around the uterus there. Positive or negative? Yeah, so there's a little line of fluid that's tracking all the way through there. Something that looks kidney-ish over here, something that looks maybe spleenish over here. In the space between the two, if I just look right there, there's some shadow in the way. I wouldn't call that positive. But above the spleen, between the spleen and the diaphragm, and all the way around the tip, lots of fluid. How about here? Right upper quadrant, lots of fluid all around the gallbladder sulcus, bowel swimming in it. None of that is supposed to be there. Another kidney, either spleen or liver. Not just in the line between the two, but over here around this tip of the liver, free fluid. In the left upper quadrant, talking about that fan, that clear fan up into the thorax, we talked about that in the hands-on session as well. You're going to angle up, look for that diaphragm, and you want to see junk. You want to see schmutzy, gray, nice, aerated lung above the diaphragm. You don't want to actually see the lung flapping in the wind. You don't want to see this black wedge there. Just another example of a pelvis with a lot of free fluid. This is a transverse view. And this is the same patient in the right upper quadrant. It's more subtle here than it is here. This is bowel floating in a sea of free fluid. Moving on to some pitfalls, and then we'll go into thoracic. We've got 10 minutes. In the left upper quadrant, those of you who rotated with me for the hands-on, one of my great tips of the day is I do my right upper quadrant from the anterior axillary line. I don't put my hands way back here, like next to the kidney in order to see Morrison's pouch. I do everything from the anterior axillary line because you have that beautiful blood-filled liver that makes your pictures look so good. And it lets you take a few centimeters back and gives you more perspective of the whole right upper quadrant so you can see. You can fan all the way through Morrison's pouch and see around the tip of the liver and see up into the diaphragm from the anterior axillary line. You can't do that on the left because there's a stomach here. And this is that stomach filled with gas. It looks like fluid. It doesn't look like free fluid. It's black. It's got a bunch of white stuff in it. And it's kind of washing everything out as you fan through it because there's a lot of bowel gas there. Another pitfall, and a really important pitfall, is I talked about it a little bit already. Fan all the way through the organ that you're interrogating because you could put your probe on here and right at the beginning of that clip you could say, oh, that's a normal transverse bladder. It's got that rhomboid shape. I'm cool. I don't see a lot of fluid down here around it. But if you fan all the way through and look for that nice rhomboid bladder to close itself off and be well contained, you won't find it because this is actually free fluid just sitting in the pelvis, and the pelvis is kind of rhomboid shaped, and you're mistaking that the iliac crest is filled with fluid for a bladder. So fan all the way through, you're going to want to see this fluid kind of get rounded off and be contained, and it's not happening here. This is the same phenomenon. Part of this looks like normal bladder when we first start, but the fluid never goes away here in these corners, and the bladder is down here. Cysts. I talked a little bit about cysts in the previous lecture. If you see something that's like perfectly round and black, probably a cyst and not free fluid. It may or may not be normal. It's normal to have cysts in the soft tissue, kidneys, liver, etc. And when you're doing a fast and you see a kidney cyst or even a hepatic cyst, you could be fooled. But just keep in mind, free fluid's not going to make it show up into a balloon unless it's a cyst most of the time. So that's a pitfall. And then I also talked a bit about the double line sign. Remember that? Perinephric fat and gorotus fascia. This is another example of that. When you're in a hurry and you're dealing with a trauma and you're trying to get it done, when you're rolling a patient from side to side, you can mistake that hypoechoic stripe there as free fluid. Fan all the way through it, see if it's kind of gray, see if there's any other evidence that it's kind of creeping around corners to decide whether it really is or isn't fluid. This is double line sign. This is actual fluid. See the difference? Oh, this is a guy who, one of Dr. Moore's patients, he told me about. A guy who came in, got into like a domestic thing at home. He'd been drinking. Somebody hit him with a table. His back hurt. He came in. He wasn't really tender, still drunk. Had a fast done in the morning at 11:30 a.m. I think he either was discharged. He was discharged and came back. Later that evening, was sitting in the waiting room waiting to be seen for a second time, and he passed out. He's hypotensive, tachycardic, and a repeat fast. And this was his spleen. So it is not within the scope of your ED practice or fast exam to diagnose splenic lacerations and ruptures. But if you see a bunch of blushy blood and abnormal material in a spleen, and you've seen a bunch of other ones that don't have that, high index of suspicion that you have an injury. And these don't always leak. And these don't always become hemodynamically stable right away. So look, and like I said, the machine will start to teach you. You don't have to know exactly what you're looking for, just look every time. And repeat your fast. And that's kind of the point of this slide. The ACLS indication for a fast exam is hemodynamically unstable blunt trauma. But that's too narrow. That's the definition for them, but it's so much more useful than that. So do it in your hemodynamically unstable blunt trauma patient. Do it in your hemodynamically stable blunt trauma patient. Do it again. You can use it for the same windows, the same views, the same sort of interrogation for a host of other things. There's a rush protocol. You can assess for hemorrhage, hydration, AAAs, heart failure. I do echoes on everybody with chest pain or shortness of breath every time. Because you're going to pick up and be able to tell whether somebody's asthmatic or having a COPD exacerbation versus congestive heart failure. Chest pain, you can tell if somebody's having a heart attack. I diagnosed an in-progress myocardial infarction that wasn't a STEMI yet in triage. The EKG didn't meet STEMI criteria. Guy was having chest pain. We get a lot of those. I took the ultrasound machine to triage, and he had a focal wall motion abnormality. And I called the cath lab from triage, even though there wasn't a STEMI. He STEMI'd like 10 minutes later. Grab it, use it, look. And of course, all the bowel stuff we're going to talk about in lectures. And then there's this. This is America. It's where we live. A little bit of a reality check. So the point of this slide is it's going to be difficult. It's going to be limited. If you're not sure, don't call it positive. Be sure, and when you're sure, you'll be right. If you're not sure, get a secondary exam. Get a confirmatory exam. We only have another couple of minutes. Thoracic, we kind of already talked about. We already talked about the pleural line and pneumothorax. We already talked about hemithorax. You can also see interstitial lung disease, pulmonary edema, pulmonary fibrosis. You can also look for rib fractures, which we can talk about in the hands-on section, and you can see a few other interesting things. Everything that you see in the lungs, in the chest below the pleural line is artifact because it's supposed to be aerated lung. There's normal artifact, that what you expect the pattern to look like, and then there's abnormal, and that's what you're looking for. So you'll see a pattern of lines. A lines are reverberation artifact from the pleural line. So this pleural line is here, and because it's very reflective, it will reverberate. Kind of like a piece of metal, if you scan a piece of metal. It'll reverberate, and they're very evenly spaced, perfectly evenly spaced lines. Those are A lines. Those are normal, unless there's a pneumothorax, in which case they're abnormal, because you can get A lines even if you have a collapsed lung. B lines, or Z lines, are these little tiny tails that come right off of the pleural interface. What happens is the There's 2 layers of pleura. There's little micro air bubbles and surfactants in there, and those little imperfections as those tissues slide against each other create artifacts. Even in normal people, there's always a little bit of artifact, and they create these little tails. In a normal aerated lung, if everything below there is aerated, then they kind of disappear, like tiny ripples in a pool. But if there's a lot of fluid, if there's a lot of pulmonary edema, and those lungs beneath it are very wet, all these little imperfections will continue to be propagated because of all that nice, wet, spongy tissue that's carrying those lines forward, and they won't dissipate after just a few centimeters. They'll keep going and become V lines. It's physically, the physics of it is the same process. The difference is they're getting propagated through wet lung here, and that's pulmonary edema or alveolar interstitial tissue. There's some pitfalls there. There's pulmonary fibrosis can look a lot like this. ARDS can look a lot like this. But that's the difference. So when you're trying to determine Z lines versus V lines are tiny little wispy ones, and they usually dissipate in less than 6 centimeters. Drop your depth to 12 or 16 centimeters, and if they're still going the full range of the field, and if you see more than 3 of them on a freeze frame, then those are pathologic V lines. The asterisk is, we're talking about looking in the anterior chest. There's a physiologic mismatch between VQ in the dependent portions of the lung. So if you're over here, you're going to see V lines, and that's not necessarily abnormal. So this is anterior chest stuff. And we're pretty much done. There aren't any set rules as to exactly where to look. There are a bunch of protocols out there that you can kind of look up. You basically just want to get a good look all over the anterior chest, and the hemidiaphragms, and as much of the rest of the lung as you need to get the information you're looking for. COPD, CHF, pneumonia, ARDS, you can actually see some evidence of pulmonary embolism. There's some people working on the reliability of ultrasound for looking at sort of these wedge necroses that happen when you have pulmonary emboli and how it creates changes of the pleural line. I'm not up to speed on that yet, but it's kind of interesting. It works, it's been demonstrated, and that's it.
Thank you so much, EMS Nation, for listening to our EFAST lecture. Let us know your thoughts. Is this something you could potentially use in the pre-hospital space, or are you already using it in your clinical practice? We would love to hear about your experience. Please tweet us at EMS_Nation. And check out our Facebook page at www.facebook.com/prehospitalnation. This is Faizan Arshad wishing everyone a safe tour.